Each presenter will get 10 minutes to present their presentation. And one of our in-person presenter is on the way. She will reach shortly. Thank you.
Distinguished guests, ladies and gentlemen, my students, fellow colleagues, it's a pleasure to welcome you all to this session on health economics. This is a very important session. We know that many of our Southeast Asian countries are striving towards universal health coverage, but investment in health remained historically low in all of these Southeast Asian countries. We are in a critical condition where we faced COVID-19, then Russia-Ukraine war, and there are political unrest in the country, in Bangladesh especially, and also in Nepal, and now the fuel crisis. So all these left us with more severe fiscal space crisis, and that led to even more non-prioritization of health investment in these countries. So I think this session is therefore really very important because we need to reprioritize the investment priorities for health, and we should focus on achieving universal health coverage to ensure equity, efficiency, and also resilience of the health sector. We should ensure that the national budget should prioritize health sector in all these countries. If we don't do it, if we fail to do this, then out-of-pocket health expenditure will go high, and that will create another inequity within the society. So I think this session will shed light on some of the priorities of health investment, and we'll come up with some solutions that will help us to translate policy into research into policy and practice and action. So without further delay, I would like to request our first presenter, Padam Raj. Sorry if I misspelled the name. So you have your 10 minutes for the presentation. Yep. And there is a volunteer here. We will show you the timing. So over to you.
Present from here.
Good morning, everyone. My name is Padam Raj. I am a teacher. I teach economics at one of Tribhuvan University affiliated college in Kathmandu. So let me begin with my presentation. A few months back, I was reading news about non-communicable disease in Nepal, particularly about the burden of disease, right? How non-communicable disease is spread the burden to this society in terms of health and in terms of economic finance. And then later on, I started searching some data, right? What actually happening about NCD globally and also in Nepal. And I found that globally, non-communicable disease is one of the growing concern among people. And if you see the data, like around 15 million, around 15 million premature deaths due to NCD, nearly like more than 86% of the death that occurs in least developed countries or countries like us, right? And the second data in Nepal, by Nepal Burden of Disease 2019 report, that shows that around the total estimated death, nearly more than 70% of death is due to the non-communicable disease. So that can be a kind of seriousness about the non-communicable disease, right? And there are like two economic issues. Some people say that, many people say that the non-communicable disease is a disease of the risk. And I was talking to one professor in Nepal, a health economics professor. He was saying, yeah, non-communicable disease is a disease of risk, right? And then I started thinking like, why this is a disease of risk? Because there could be two things. One is, if you see from the cost side, then the rich people, they get overweight. There is like obesity issue, so they are likely to suffer non-communicable disease. That is cost side. And if you see the treatment side, then only rich people can afford to treat the non-communicable disease. So from both sides, you can say it's a disease of risk. Then 2 days back, I just searched in Claude AI, and it said like non-communicable disease is not only a health issue, but it's a poverty issue, right? And I found it quite interesting. That then I started quoting here, right? So then I looked into the data, right? And, I used Nepal Living Standard Survey data set, and there is, if we see there, then there are like basically four sources of financing the non-communicable disease, right? There are four ways to finance it. Basically, own saving, people can sell their asset, they go for borrowing, they pay for subsidy or get insurance and others, right? And then I started thinking like, does this type, five, six types of financing sources have different impact into the different expenditure quintile, right? So is there any kind of heterogeneity issue into the expenditure or into the effect of the non-communicable disease financial sources? And accordingly, I frame my objective to examine the effectiveness of financing sources on non-communicable disease expenditure, right? So these are the literature, and several studies are going around. If you see in Pakistan, there is one study, and in India, in China, right? So they have done a study on non-communicable disease, particularly double disease burden, right? And those things. And and then if we see in Nepal also there are a few studies that they focus on the linkages of non-communicable disease on health expenditure, particularly out-of-pocket expenditure or catastrophic health expenditure. And there are some small sample size survey, for example, this Kaple Adhikari in 2025 in Pokhara city, right? And these are the study, and so if we see the research gap, then based on my knowledge, right, there are two things that I found. One is no such study, to the extent of my knowledge, no such study found using the nationally representative latest data set that examining the linkages of financing sources of non-communicable disease and its expenditure. And secondly, none of the study found using the quintile regression into that particular set of data on particular the association. So my data source is I use the Nepal Living Standard survey data of 2020 to 23, and my prime variable is outcome variable, dependent variable. That's a household total expenditure on non-communicable disease, and that is that includes the these sort of costs. For example, outpatient costs, emergency costs, laboratory, and so on. These costs actually makes the 1 minute left. Oh yeah, that's sure. So my independent variable actually the sources of financing, and the other collaborate that I've used is like socioeconomic demographic factors such as household health, gender, and so on. And then I perform the Shapiro test to check the data normality, whether there is evidence to go for the quintile regression, and that the evidence provided the skewed nature of data, and that gave me evidence to go for quintile regression. So accordingly, I went to the quintile regression. That I have like 4, 5 quintile, 10 quintile to 90 quintile, right? And the key finding is the selling asset has like positive association with the non-communicable disease expenditure across all quintile, but it is more effective into the 10th lowest quintile and the upper quintile, 75 and 70 quintile. And the purpose is it's about distressed financing, right? People, and there are we can see like in the lower quintile, people sell their asset. What kind of asset they sell? The nature of the asset is like they sell productive asset, livestock, farmland, and so on. But if you see the richer people, they sell the asset like they sell more non-productive kind of asset, maybe gold, jewelry, and so on, right? And if you also see the purpose. Poor people, they have to survive. So what they do, they sell their buffaloes, right? They sell their chickens, right? And for richer people, maybe they may be looking for the good quality health or quality health care and so on. So that's why they are selling the asset. That purpose wise, it's also different. And if you see the effect also, so what if poor people sell their asset, then that is likely to make them poor, right? Impoverishment is the issue. But if we see the rich people case, if they sell asset, they are not going to be directly poor, but they are still above the poverty threshold. So I have just seen into three, like nature, purpose, and effect. And loan financing is positively as statistically significant, but it is more effective in 10th quintile. That means the lower, expenditure quintile people, say the poorer people, they prefer loan financing because they're the only option, right? They don't have the asset or they don't have the such savings, so they go for loan financing or the borrow. I found insurance has the mixed effect, right? And the literature shows that insurance may increase the household expenditure because they have got received insurance from some sources, and also that may reduce the expenditure because government or some other agency they are bearing their cost, so that may also reduce the expenditure, and accordingly the per capita expenditure, size of the household, education, these factors also found to be significant, and these are my quintile results. Right, selling asset is more effective in first 10th quintile, and then 75 and 90th quintile. Loan is more effective in the lower quintile, 10th quintile, and so on. Right, these are the control variables. So here's my conclusion. Based on my finding, I can say that the financing sources have the heterogeneous effect across the expected quintile. The effectiveness varies, right? But methodological caveat, I must acknowledge, I'm not very expert into health economics and particularly into the quintile regulation as well. So I must acknowledge that
Thank you, Padamraj Panadu, for your nice presentation, especially you were within the time, so thanks for that. We'll hear from the discussants later, but we'll finish the presentation first. We will go to the online now. Can we just check if our presenters are available online?
She has joined a different breakout room. I'm trying to assign her in this breakout.
So who is here now online?
So the
Tasneem. Tasneem. So our next presentation is by Surya Tasneem Kabir, parental involvement and children's mental health evidence from Bangladesh. As soon as she is in the right breakout room, we'll hear from her.
Can you guys see me and hear me?
Yes, we can hear you.
Yeah, let me share my screen.
We can see the screen now. Thank you. Over to you.
Yes. Give me 1 second. Let me just. Hello, everyone. I'm Sayyidah Tasneem Kabir. I'm a first-year PhD student at University of Houston, USA. The paper I'm presenting today is Parental Involvement and Children's Mental Health and Evidence from Bangladesh. My other two co-authors are Dr. Shahadat Hossain and Saurabh Kumar Paul. From parental involvement, we meant parental care and effort. Parental care is fundamental to children's cognitive and emotional development. And recently, economists increasingly recognize that early life mental health shapes human capital accumulation, affecting their educational attainment, labor market productivity, and long-term economic mobility. In contrast, poor mental health in childhood is linked to worse outcomes in education, labor market, and adult health. Despite these facts, lower middle income countries has very limited access for formal mental health services, and also there are some stigmas that prohibits them to get treatment for their mental health. Parental role play a crucial role for psychological development of children. Warm and nurturing relationships between parents, children foster emotional resilience and high self-esteem among children, while neglectful practices increase risk of anxiety, depression, and behavioral challenges. A parent can involve with their children with daily interaction and engagement, and also especially in medium income countries where the institutional support are very limited. The motivation and gap in our literature is most studies in parental involvement focus on the association with their children's academic outcomes. While it is valuable, but this focus actually overlooks the broader implication of parental involvement of mental health of children. Also, more studies are based on high-income countries, and there also mention about the correlational strategies. They do not to study much in causal section, and also the studies are based on adolescence or early childhood. There are very few studies that has been done for primary school children. Our research question is, how does parental involvement affect primary school age children's mental health? Here is our conceptual framework where we showed the household decision model for parents, and parents actually derive their utility from their own consumption and their children's mental health. And for the subject of budget constraint, parental involvement is where Y is the income, household income, and or potential household income, and E is the parental involvement effort, where P is the opportunity cost. The opportunity cost is based on like the parent can utilize the time with either giving time to their children or they can earn or more income. This is our production function, which is for mental health, and where mental health is the function of parental involvement effort. Hygiene environment. Hygiene environment also is function of effort, and also parenting style, where parenting style also a function of parental effort. And theta represents the child innate ability, which is observed by parents. X is the exogenous household and child characteristics. This is our utility function. Here we have substituted the budget constant and production function. And you can see in the left-hand side, marginal cost of effort, which is lost consumption. And right-hand side is marginal benefit from the direct and indirect efforts. And overall, it is the, can you see my, I'm sorry. Overall, it depends on if the marginal benefit is more than marginal cost, the parental involvement give the effort. This is our total effect of parental effort on children's mental health, which interpret as direct effect for emotional support and security, and indirect effects like hygiene mechanism, like cleaner household or living conditions, parenting style mechanism, like positive or negative disciplines or parental discipline. And indigeneity concern is that the child might have innate ability. Sometimes the effort of parent depends on the child's innate ability, lower or higher innate ability.
I think just to mention that you have less than 5 minutes now.
Okay. Let me skip the data part then. So our treatment variable is parental involvement, which measured based on 5 binary indicators, as you can see from the screen. And this we have standardized and principal component, we used principal component analysis to accumulate the indicators. Outcome variable was cognitive difficulty, which was based on mother's responses. We used 4-point Likert scale. And also we found that there are 14% of children have cognitive difficulty. Our second outcome variable is behavioral difficulty, which was also based on mother's report. And we found here that 15% of the child have behavioral difficulties. Our third variable was emotional difficulty based on mother's report. And we get that 17% of the children has emotional difficulties. We also did some control for control variables in child and parent characteristics and district characteristics. Our method is, this is the simple linear regression model, where we show the parental involvement on effect of parental involvement on child's mentality, where we consider that there are some endogeneity biased. To address those endogeneity, we have used instrumental variable, and we use local parental norms as our IV. This shows that the IV actually affect the children's parental effort, but it doesn't directly affect children's mental health outcome. And we showed in the IV, it shows the strong relative correlation with the effort, but it indirectly affect the Y. This is our reverse causality concern. We address the OLS and IV, both of them. And as you can see, we check the main result was the effect of parental involvement. As you can see, parental involvement is negatively related with cognitive difficulty and emotional difficulty, which is significant, though we didn't find any significant result in behavioral difficulty. We did some robustness check, and our mechanism, household hygiene environment, we did improve toilet, hand wash facility, safe water, treat water, hygiene index, and safe hand washing. From parental environment perspective, we got positive association and significant result for that. And for parenting style, we get negative and positive parenting. For negative, it was shouted at child, shook the child, and beaten child. That gives us a negative association. And for positive parental involvement, it gives us positive association with parental involvement.
I think the last minute for you.
Yes. So from our paper's perspective, we did our research on low and middle income country, which is Bangladesh, which has limited mental health service and some high stigmas. And we use causal evidence. We use a very strong instrumental variable to address the endogeneity. And we use two mechanisms, parental style at home hygiene practice. Thank you for your time. If you have any question.
Rasmin, please stay with us. We'll have question answer session later. So we'll come back to you.
Okay.
Now I request Selima Sarakabi to present.
Why I can't stop sharing?
Please sit and see the presentation.
Good morning, everyone. Thank you so much for your patience. I apologize for being late. My name is Salima Sara Kabir. I've been working with the Bragg James P. Grant School of Public Health for almost 7 years now. And I've been working on a variety of topics. I want to first caveat by saying I'm a qualitative researcher, so you're not going to see as many numbers or as much statistical analysis in my presentation, but I think hopefully what I'll be able to highlight is the importance of combining tools of mixed methods analysis in terms of looking at health, because oftentimes when we look at health in silos. We look at health in terms of just health outcomes, just health indicators. And what I try to do is bring a more holistic approach to understanding the different barriers to accessing healthcare. So just to give you a brief focus on the context in which the study was carried out, this is actually a part of a much larger project. It's a 4-year project that is almost wrapping up now around the mental health of community health workers. And we were working primarily, we worked with BRAC and with the government to understand how different factors affect the mental health of community health workers and how we can improve their sorts of let me see if I can get to the. I just want to go to the study sites first before I go to anything else. So what we looked at is we went to 2 sites, Mamanching and Boishal, and what we were doing there is mainly collecting data on how community health workers are feeling, what their how they sort of rate their workload, the impacts of the work that they're doing, whether or not they feel like they're being fairly treated, how we can improve their working conditions. That was the main objective of this project. However, when we started doing the work, we were also collecting some GIS data. So we were collecting whenever we went to households, because we were also assessing households on, are you satisfied with the care you're receiving from your community health worker? How do you think they can improve? What do you, when you witness them, and if you're oftentimes community health workers, because they come from the communities, they're family members, household members. How do you understand their conditions? How do you understand their, so that we understood, we got a community perspective as well, because only understanding the community health workers perspective was not, it wouldn't give us a complete picture. So when we started doing all of this, and this was also a mixed method studies, we did surveys as well as very in-depth participatory community-based approaches. Where community health workers did like very exciting tools such as body mapping. We did something called photo narrative. But one of the things that was interesting to me is we collected a lot of GIS data. So we collected household locations from the households. And we weren't able to use that very meaningfully for the, at least not yet, for the community health workers. But while I was doing this project, there was a master's built into it, and I did my master's in public health at the Liverpool School of Tropical Medicine. And for that, I wanted to sort of stretch myself and explore what it means to do quantitative research, or, you know, like a little bit more analytical research outside of the qualitative realm. And so I wanted to do GIS mapping. And so I use some of that data to explore how distance impacts healthcare access. I'm going to be very sort of honest with you, because it was my first time doing a lot of statistical analysis. A lot of it is just very simple descriptive statistics. It's not very in-depth. We're not doing sorts of I wasn't doing a lot of comparative work in terms of trying to understand, but what I was trying to assess is essentially how does distance impact, because whenever we look at distance, one of the things that I try to do is look at distance beyond just this like Euclidean line, which is the straight line mapping that we typically do. So typically whenever we're looking at the impact of distance, and this I sort of talk about in the sort of need for this study, is whenever I started looking at papers and trying to do a literature review around this, I kept finding that people, one, just refer to distance very vaguely. It was alluded, yes, distance is a factor, distance is a factor, but no one really looked into like, why is distance a factor? How is distance a factor? Like, what are the ways in which distance is being impacted? And almost always the distance was being used as a Euclidean distance, which is just, oh, from my house to this point, when I draw a straight line, what's the distance, and does that have an impact? But in reality, because we were going to the field very regularly whenever I was in Borisha, they have howers, they have rivers, flowing, little water bodies flowing all across the land. So it was impossible for me to say, oh, like from my house, it's a straight line to the health center. That's never the case, right? So I thought it was a very sort of incomplete picture, and I wanted to explore more on how does distance actually play out. And I tried to look at the different varying factors, and I sort of combined my analysis a little bit with the qualitative research that I've had, because I'm a qualitative researcher and I cannot extricate my qualitative analysis from anything. But what I sort of started looking at first is, okay, how does the Euclidean distance impact? And one of the first shocking things that we found is that even when we're looking at just general distance, like very straight line distance, people are having to walk very, very far. People are having to walk. Even if I just do basic straight line distance, you can see here that a minimum of 4 kilometers is one of the shortest ranges. It's 200 to 4 kilometers. 4 kilometers is not an easy walk. And then some of the larger distances from these points would be over 16 kilometers. So someone is having to travel 16 kilometers just to access healthcare. And this is the Upajala Health Complex. I was looking in terms of sort of broader health impacts. So like your community clinics, and another reason for looking at Upajala Health Complexes, and this is context that comes from our project study, is the fact that we found when we were working with community health workers that a lot of these sites that we were working in, the community clinics were not actually operational. While there are informal clinics, it's very hard to measure who's going where and what kind of services they're looking at in terms of private. So I wanted to look at something that's concrete, that I know people are definitely going to for tertiary care, and that's the Upajala Health Complex. And so I tried to look at, well, every Upajala that we looked at has an Upajala Health Complex. How easy is it to access that Upajala Health Complex? And you can see that for some of these sites, the distance is very, very far. People are traveling very long distances. But again, this is not people, we're not flying there, right? We're not taking like a straight line route. So what does it actually look like when they start to travel? So then I started mapping roads. Now, the first challenge that I faced in doing this is obviously the fact that we don't have a lot of network mapping done in Bangladesh. It's especially in rural areas, it's very difficult to find actual network maps. So we used open source maps, but it's very difficult. And so one of the first things that I want to highlight is, as a takeaway from this, is that we need to do more GIS work in general. There needs to be more work done, especially when we're combining these sorts of tools with health, with other forms of research, because otherwise we're going to always come up with incomplete data. So as I started trying to map these roads out, I realized this will also, I mean, I'm just going to be very honest. I don't believe 100% in this analysis, simply because I think there are lots of smaller inlet roads, smaller paved roads that people take that are not visible on the sorts of network maps that are available in these. And so we need to do more grounded mapping when we do our work, because this grounded mapping becomes very essential in terms of understanding how people are actually traveling. Because I think the roads that we're seeing here may not be the real roads, but I think it still sort of gives us a good indicator. I think if we look at some of these, like for example, this one is probably not a very accurate road map, but if we look at something like this, or if we look at something like this can give us a better picture of where, I don't know, can you see my cursor? So in the Moyman area district, if you look at the top sort of top right corner, that I think might be sort of a relatively reasonable map to sort of address. So if we start looking at that, and we start looking at how does it impact, and we see that the distance increases. So now my range has gone from 4 kilometers being the shortest range to 6 kilometers, more than 6 kilometers, like almost 6.3 kilometers, right? So this distance has already increased. It's growing. So people are having to actually travel far more than we're assuming when we start doing this kind of research. Then I started thinking, well, I want to really look at water bodies. Why do I want to look at water bodies? Because I remembered a quote from a participant saying that when they were going to access a health facility, they had to take a boat. And oftentimes women are not able to take that boat because if they don't have a male chaperone, then they aren't allowed on the boat sometimes. Or if it's at nighttime, and these are things I'll also explore, but I'm just giving you a little bit of a I'm just trying to be mindful of time, so I'm giving you a lot of these information at once. But when you're looking at, this water body becomes a very important factor, because if I'm trying to cross over, how many times am I crossing a water body? And so again, if we start looking at this, then you can see that the maximum number of water bodies that people might have to cross in order to access health care is 3. So just on one road, you may have to cross 3 distinct water bodies, or maybe one water body. 5 minutes? Or...
Its time is over.
Okay. Okay. Now I'll be very quick.
Last 1 minute.
So basically, you have to cross these water bodies. And again, as I was mentioning, this has a gender impact to it as well, right? When we're looking at these sorts of things, which we have to be considerate of of how these distances and these, geographic factors impact our access to healthcare. And this is just a very preliminary work, but I think it sort of highlights all of the different ways we're still limited in how we're thinking about access to healthcare. There's so many different factors we need to consider, and this really requires in-depth, on-the-ground research, and it requires interdisciplinary work. So just because I'm working in health and I'm working with qualitative data doesn't mean that there aren't intersections, because oftentimes when we look at costs, we're only looking at costs of the services. We're not looking at the cost of travel. How are people getting there? To get across these different roads, they are not only having to buy transport, having to change transport so many times. All of these factors also come into consideration, and healthcare becomes far more expensive than we actually account for. So it becomes a very important thing for us to look at. Thank you.
Thank you. Thank you, Selma, for the nice presentation. So now we have the last presenter online. So maybe we can invite Dr. Milind Kumar Yadav from India to present.
Hello, am I audible?
Yes, you are.
Okay, thank you. I'll just share my screen quickly. It's 5 minutes gone. Okay, is my screen visible?
Yes, but not in the presentation mode. Maybe you
Okay,
can
okay.
keep the presentation mode. Yes, thank you. Yeah,
Okay.
it's visible now.
Okay. Good morning, everyone. Myself, Dr. Milind Kumar Yadav. I am currently teaching at Christ University Pune Lavasa campus. And today I'll be presenting on the topic health insurance in India, patterns of use, financial implication, and behavioral concerns. Okay, before starting with my main presentation, I would like to introduce to the topic. And in that, I would like to discuss what are the problems that are there with health insurance and why we need health insurance, and then accordingly, and the impact of health insurance on a particular vulnerable population that I have selected for my study. So, Sustainable Development Goal Target 3.8 tries to, or in a way, to achieve universal health coverage by 2030. That is our target. But we are in 2026 and still we are far away from this target. And still, lot of the population, almost half of the population is still deprived of necessary healthcare. And if you see in numbers, so 12% of the individuals are still having some sort of catastrophic health expenditure. That means their larger portion of a major portion of their income is going on health. So this number can vary depending on the definition that we are taking. So, for example, 10%, WHO has taken 10%. If expenditure is more than 10%, it is catastrophic health expenditure. And the number in India is more alarming. It is 17%. Apart from that, we have unmet healthcare need also. So 12% of the population is not able to meet the basic needs also. So, and also more than that, we also have the access to healthcare is also unjust as reported by several studies. Now, on the other hand, we have economic burden of out-of-pocket expenditure, and just to get into the number, so because of out-of-pocket expenditure, catastrophic health expenditure is going 47.8%, and because of that, 15% of the individuals are getting impoverished in some way or another. Similarly, if you're talking about inpatient or hospitalization, catastrophic health expenditure is 43.1%, and it leads to 10.7% of people, individuals to get impoverished because of this out-of-pocket expenditure problem. Now, there is another problem that is also alarming, and this is the reason why I have selected people above 45. So, increasing burden of disease is one problem that is there, and especially in India and all over the world. So if we talk about India, cardiovascular disease account for 28.1% of all deaths in India, followed by chronic respiratory disease, that is 10.6%, and cancer is also 9.6%. Moreover, we also know that diabetes is another major concern, and that's why we also called diabetic capital of the world. India is again in that picture. But the thing is that, and because of all those factors, these who is more prone to get all these diseases? So people above 45, we are taking for this study because they are more prone to all these non-communicable diseases. And that's the reason we have selected them as a population. If we compare India with some other countries like China, Brazil, South Africa, and even if we compare take average of lower and middle income countries, the numbers are not well. So if we see that India domestic general government health expenditure as a percent of GDP, it is 1.12%, and that is a problem with major countries. If I talk about Bangladesh also, the number is just 3.31%, which is again not a very good number. If you talk about current health expenditure as a ratio of GDP, again, as compared to, you can see Brazil, where 9.89 is the expenditure, but in India, it is just 3.28%. And similarly, out-of-pocket expenditure, which should be less, but again, it's very high in India, that is 49.82%. Again, the number for Bangladesh is also very high. It's almost 75%. Now, so one part is in this study that I am taking is the impact, the health insurance literature, the theoretical framework, and in that I am also taking moral hazard as one of the case. So that is a behavioral change that people have because of insurance. So these are some of the theories that I mentioned. Expected utility theory, which originated the health insurance. Then Grossman in 1972 discussed that health insurance demand derives from the health service demand. But again, access motive is also discussed by Neyman in 1999 and after that also. So insurance, we can say that if you have insurance, maybe you are utilizing the healthcare services more. It can be a problem of moral hazard. But as Neyman mentioned, that you are increasing your healthcare utilization because you are not able to meet those expenses earlier. So it may not be moral hazard also. So we cannot always say that if because of insurance utilization increasing, we cannot always say that it is moral hazard. So that's what we will see with the data also.
You have less than 5 minutes now.
Sorry.
You have maximum of 5 minutes.
Okay. Yes, ma'am. Okay, now, obviously, objective I have already discussed, evaluate the impact of health insurance on vulnerable population in India. So the data which I have taken for this is LASI, Longitudinal Aging Study of India, 2017-19, where 73,398 older adults are covered, and most they are more than above age 45. The method that I'm using for this study is quasi-experimental method, that is inverse probability weighted regression adjustment. Why this method? Why not PSM? Because this method combined two basically methods: inverse probability weighting and regression adjustment. So, which is again a doubly robust method. Even if one model is correctly specified, we will be able to get the result. Treatment: we are taking publicly funded health insurance, that is PFHI, and PHI is private health insurance. Outcome that we are taking for this is healthcare utilization, out-of-pocket expenditure, and self-reported health. Now let's come to the result. So here we can see that the impact of health insurance. This is for publicly funded health insurance, PFHI. So ATT is the average treatment effect, and then accordingly we have our significant value. So here we are seeing that because of publicly funded health insurance, the number of time hospitalization is increasing. So it may or may not be the moral hazard, as we were discussing, as it has been discussed in the literature, that if because of health insurance, if your hospitalization is increasing number of times, that means it can be the possibility of moral hazard. But here it is increasing, we can say, but we are not sure. Then we'll go for out-of-pocket expenditure. So out-of-pocket expenditure in this case is decreasing. And just to be sure that whether it is a health insurance or not, we have taken the outcome variable, that is self-rated health. And here we can see that higher the number, so the lesser the outcome actually in this case. So the positive result is showing that the self-rated health is not in a good position. So even though their number of time hospitalization is increasing, their self-rated health is not in a better position. That means there is a problem of moral hazard in publicly funded health insurance scheme. We cannot say the same for private health insurance. So in case of private health insurance, again, number of time hospitalization, we have not find the significant result. Out-of-pocket expenditure is increasing, but their self-rated health is in a better position. So categorically, we cannot say in case of private health insurance, but we can say in the case of publicly funded health insurance that there is a problem of moral hazard. Okay, so this is what we got from this study, that publicly funded health insurance scheme enhances the number of hospitalized for insured, which suggests that there may be the possibility of exposed moral hazard in PFHI. However, as we know that countries like India, Bangladesh, and other developing countries, access is a very big problem. So even basic needs are not met. So maybe because of health insurance, people are going for that basic need, and that's why we are seeing that increased utilization. So what we can say that there may be a possibility of moral hazard because self-rated health is also not good. And on the case, on the other hand, we do not have the data to prove that whether there is a possibility of health moral hazard in case of private health insurance. So yeah, thank you. That's all from my side.
Thank you, Dr. Milind, for your nice presentation. Please stay with us. We will open the floor for questions after we hear from our discussant. So now I request our distinguished discussant, Dr. Islam Abdullah, to get his reflection on the 4 presentations and some concluding remarks based on all the 4 presentations. Thanks.
Thank you, ma'am. Very good morning to you all, and I congratulate all the 4 presenters for being on time and doing such a great work. So I believe all our 4 presenters are now relieved, but in this room, who is more scared now is me, because I'm just sitting next to my supervisors, and I'm the student who have submitted his correction just yesterday evening. So you can realize the situation to me. So I will try to go on time definitely and be specific. So this is indeed a well-charted session, and the papers cover different areas from insurance to NCD financing, special access, and child mental health, most importantly. But they all point to one common issue of health economics. And what's that? So the main issue in health economics nowadays is how financial, spatial, and social constraints shape health outcomes in low and middle income countries. So I believe this is the particular point where this all four paper comes together and can be combined. So I will try to be, more focused in terms of providing my comments and suggestions to the supervisor, and I will structure my discussion in three areas for all the four papers, focusing first on identification causal claims, then the conceptual clarity that they have used in their papers, and what is genuinely new, what was the novelty of the work. And obviously, at the end, I have some common suggestions for all these, four presenters. So let's begin with the first one, NCD financing in Nepal, the first paper. It particularly covered how households finance non-communicable disease care using, quantile regression approach. So let me start with the strength. So the method is appropriate for this paper, and it nicely, showed the heterogeneity across the expenditure distribution of the households. And obviously, quintile regression is the appropriate method if you want to, recover the distribution of any particular, issue. Then you have to rely on the quintile regression. And the patterns the paper actually found is quite intuitive. Like, poorer households borrow more, distress financing rises with higher costs, and insurance plays a limited role, kind of a mixed effect. So the results were more sort of conventional and expected. But what three things that concern me about this work is most of the people here in economics, economists, and that's endogeneity. So financing choice, to be frank, is not random. You can talk about any household, even in high income countries. Financing choice, healthcare financing choice is not random, and it is driven by actually how severe and costly the illness was, how severe was the incident was. That actually drives the financing choices. And so what we have seen in the paper, if you see the flow of the development of the findings of the paper, you will see that it shows that severe illness leads to higher expenditure, and higher expenditure leads to borrowing or asset sales, not the other way around. And that brings a conceptual problem, basic conceptual problem. So currently, it treats financing as the determinant of the expenditure, but the standard health economics literature that shows us the other way around path. That means it should be the expenditure which should comes first, and based on which you will decide your financing choices. So there might be a causal direction which is reversed, and it could be a worthwhile option to explore whether this is the real case in Nepal or not. And coming on to the final point regarding the novelty. So as I said, the findings are conventional and all are well standard. But to me, it seems that application of quantile regression adds detail, but it's not fundamentally adding something new inside. So I'd frame this paper more as a strong descriptive contribution on financial distress rather than a causal analysis. And I would like to stress to the author that if this particular question can be answered, then obviously I believe it can find a good place for the publication. And the fundamental question here is, how do you deal with reverse causality between expenditure and financing sector? And that would solve the problem of endogeneity, and that would also save you from the reviewer hunch of financing choice was actually not random from the households. Having said that, I would like to move on to the third presentation on the GIS access in Bangladesh paper. When the presenter was presenting, I think you were feeling a bit left alone, since you were from a qualitative background, and you wanted to spend your energy on the mixed method research. But I can tell you one thing, that's a strength actually. That's, frankly speaking, that's a strength, because numbers cannot explain everything. So if you want to know something in depth, you need to know the context. And here comes the strength of qualitative research. So you don't need to feel left alone in the room or in the area of research work. So this paper combines GIS, which is commendable, GIS survey data, and to study the health access barriers. Strong work methodologically, and rightly point out that in Bangladesh, it's very difficult to find out mapping. It's very difficult to find out mapping nowadays. And given this reality, applying this particular method is actually commendable itself, and a challenging work. So, and using network distances instead of Euclidean straight line distances was actually an add. Again, there is three concern. You already have mentioned in your presentation that obviously you were not focusing for any causal identification, because distance is not going to be exogenous. People choice of making house and also the establishment of hospitals are not actually exogenous. It depends on a lot of external factors as well. So you were well aware about that. So I consider all the results as a descriptive one. Regarding the conceptual issue, I will say that the paper emphasizes more on the distances, but the findings show something different from the main point, that even when the facilities are closer, the utilization were low. So that was striking, actually. So a bit of explanation on that would have been, really, really interesting, that why it's actually happening. So clearly, distance is not the whole story. There might be some other issues like quality, trust, informal providers. And when I mention informal providers, I would like to just share a story here. So me and Rumana ma'am, back in our old days, we worked on traditional medicine in Bangladesh, and we published that paper as well. And we had a site in Barishal as well, where you collected your data. And the highest prevalence at that time, the highest prevalence of having informal taking service from informal providers were there. So actually, distance is not the whole story. There are some other factors that it should be considered when we are explaining or trying to developing this framework. In terms of novelty, so as I mentioned, GIS is quite common now, so the contribution needs to be sharper. If it has to move forward to the publication stage, the contribution really needs to be sharper, and we need to think in the angle that is it the case that using Bangladesh is the specialty or the uniqueness of the paper, or is it the gender? So which one? So from that angle, if we can redistribute the discussion and develop the structure of the paper, then it might be a good one. And right now, when I was reading the original manuscript, so it was a kind of contextual application, then a conceptual breakthrough. So very strong descriptive and policy relevant work, by the way. But it needs a clearer link between access and actual behavior. Why am I saying that it's a policy relevant work? Because currently Bangladesh is positioned at a stage where we always discuss about primary services. You can talk about education, you can talk about health. Everywhere primary services is questioned, and the main purpose of improving of establishing community health is to develop the primary healthcare services. So obviously if we can shed light on this particular issue, how to make them more effective and take with their service take towards the people, that would help to develop the policy and frame the policy in a newer way and make it contributory. So that's why I think it's a very good policy relevant work. Coming on to the paper related to parental involvement and mental health, I must say out of this 4 paper, this particular paper, parental involvement and mental health, was the most theoretically stronger and based on a solid foundation. So I congratulate all these authors of the parental involvement and mental health paper, because it was a solid work actually. But when I was reading the paper, in terms of the length and the development, the way they were telling the story, it was sometimes overly long. And obviously, as you all are publishing nowadays, they actually look for efficient writer. So when you want to be efficient writer, I think we need to work more on the manuscript, because it's currently a bit long. So there is possibility that you can present and you can write the whole story in a more efficient way. It used it used instrumental variable approach to estimate the causal effect of parental involvement on child mental health, and the results are also improvement. They have found that parental improvement, improves child mental health across multiple dimensions. And obviously, focusing on the primary stage children was actually an addition, which I think is a good contribution on the literature. But the whole argument depends on one thing, because personally I don't know whether it's their bad luck or not. I'm not a big fan of instrumental variable, and my friend Navin is smiling there, so I don't know what is his feeling, but the big question is the validity of the instrument. So obviously when the presenter was presenting, they have mentioned about the parental norm that they have used as an instrument, but using parental norm is intuitive, but at the same time parental norm can be problematic as well. And why is that? So, parental norms may affect child outcome directly. Just think through school quality, then it can have some direct effect through peer environment and through social context. And I believe there are a lot of other reasons as well through which parental norm can affect, child outcome. So whenever any IV is used, we can see, I mean, as a reviewer, I always put much of my effort on the exogenity restriction. So the relevance restriction is quite easy to, fit, and we will do it. And, as you know, in the data of economics and social science, if you run some regression, you can come up with some numbers. So it's easy to, satisfy the relevance condition. But the most important thing that the reviewer always look for is the exclusion restriction. And there is the point where all the writers and the researchers struggle. And whenever you struggle, you will try to contextualize your exclusion restriction and try to establish with some justification. But what I have found missing, it might be available in the main paper, but what I have found missing in the presentation, there was not a great deal of discussion regarding the exclusion restriction. How did you meet it? And if you do not meet the exclusion restriction, that puts the all estimation results in a risk. So I think adding some justification there with some quality discussion will be really good for the author. Regarding the novelty, the contribution is strong for Bangladesh, but I would say the global literature is already there. So I think more contextual extension with good causal effort would be good for this particular paper. It's a high quality paper, and strong justification of the IV and the good discussion, contextual discussion on exclusion restriction can take it to the next stage. With these words, I will again congratulate this author of this paper. Now, coming on to the last paper, which was on health insurance in India. So this paper examined insurance effects on utilization, out-of-pocket expenditure, and health outcome. So again, it's technically well-executed paper. The results are expected that insurance will increase the utilization, it would reduce the out-of-pocket expenditure, and improves the self-rate in health. But three quick concerns. First, identification. The paper used inverse probability weighted regression adjustment, and they rely, but inverse probability weighted regression adjustment rely on normally observables, and insurance uptake is likely driven by unobserved health risk as well. So my concern is there might present some sort of selection bias. So obviously, choosing inverse probability weighted regression adjustment was commendable. It was an appropriate method, because as you know that it's already called doubly robust. But I would be more interested to see why it's relevant in this particular context. So obviously it's understandable from technical point of view that it uses inverse probability. At the same time, it uses regression adjustment. That's why it's called doubly effective, doubly robust. So that's from the technical point of view. But why it's important on your in context. It shouldn't be the case that anything which is technically sound, it would be appropriate in your case as well. So we need to contextualize the method. So that particular thing was missing. And regarding the welfare interpretation when the estimation was done, so it could be more clearer regarding the welfare interpretation of the insurance and everything. And about the novelty of the work, this particular finding is consistent with the wide body of literature, but there are similar kind of work available in Vietnam and China as well. So the similar findings, like findings itself is not unique, is not new. There are people out there who actually have found that. So the key question is, what is new? What is the main contribution that the paper actually makes? So I think if the author can develop something around on the novelty of the work, that would be the main selling point of the work. So I must say that solid empirical work, but needs tighter interpretation and clearer contributional justification for taking it to the next stage. So these were my take home and my impression when I was going through the paper. So as I said before beginning my discussion, that I will have some common suggestion to all the presenters. So it's been now 16 years. I'm in my professional field, and obviously behind this side of the table, it's been over a decade. So obviously, whenever we want to present something, we struggle with time, and sometimes it's really annoying for the researcher that why time is so limited. I'm so passionate about my work, and I have to say everything. Why it's 10 minutes? It has to be 100 minutes. So I'll start by one quote from Einstein. He said, if you understand something very well, you will be able to explain it simply. So I believe there are some people in the room who are who grown up and trained up in the European culture of academics. And have you heard about the 3-minute thesis? Anybody in the room? No. Okay, so it's a huge campaign, 3-minute thesis, 3-minute PhD thesis in Europe, where you have to have summarized everything of your thesis. And if you participate in that campaign, you should be able to explain your 4 years of research of thesis, doing thesis in 3 minutes time. And here comes the beauty, that if you understand that particular topic quite well, you should be able to express it more communicative way, more simple way. So I have found that all presenters were struggling with the time. So you don't need to present every single bit of your work. If anybody is interested, they can go and they can read your work. So any presentation in terms of any research, not only in health economics or in public health, it has to cover 3 important things. The first thing is what is already there, which is what we know. The second thing is what is the contribution that you are going to make, what you have found, and the third thing is how it's going to change policy and practice. So that's the third point I have found missing in all of the 4 presenters. So if you cannot add something in the literature, if you cannot change the policy and practice, there is no point of writing pages after pages. Okay, so with the last word I would like to finish. Think before write. Thank you so much.
Thank you, Abdullah, for summarizing the key recommendation at the end, but also very clearly giving specific comments for each of the papers. So I will now open the floor. So I'll take a few questions. So please raise your hand, give your name and where do you work. Just raise your question in brief.
Hello, I'm Ambika Devnath. I'm a student of health economics in Dhaka University. So my first question was to you, Ms. Sarakubir, that you have worked on the distance, the physical distance between Gujarat health complexes and other people who seek healthcare. My question is, how do you address the mental distance? In Bangladesh, the people are more prone to seek traditional healthcare, as also sir said, and they're not they're kind of afraid of seeking healthcare. Like the difference between them and the doctor, they emphasis on that more rather than seeking healthcare to seek positive health. So how do you address that? And another question was about the health insurance. Health insurance has a lot more constraints, even if it's private health insurance, it is a lot more complex. But even if it's a public health insurance or group health insurance, we see a lot of terms and conditions. So my question is, in a low and middle income country like Bangladesh, how do I use health insurance for the lower income people that cannot really like trivials? Yes.
We will take a few more questions and then come to the presenters. Any other question?
My first question is to Dr. Milian Kumar Yadav. We take that your observation is like 45 plus people who are age 45 and above. Is it possible that you are excluding a very large sample who are likely to take insurance, terminal health insurance? Because if you take people over 45, I think it might exclude a large body of relevant sample. And another question to Alam Rajmani, that it's also relating to age. Did you consider that the fact that it might your result might vary based on pregnancy ratio? Like if there are more, you took households total expenditure as a variable. So if there are more people present, more children and more elderly people present in the household, maybe the household expenditure might be higher, or that might affect the rest.
Thank you. So maybe I will go to Dr. Milian first. So you have two questions. You follow the question.
Okay. So first question was regarding how health insurance, because it is a complex concept, and how it can be solved in case of lower and middle income countries like India and Bangladesh. So that's why we need to have publicly funded health insurance scheme, and that too, which is made especially for the people who are actually not able to access this. So that's why we have a scheme like earlier we had RSBY, that is Rashtriya Swasthya Bima Yojana scheme in India, which was covering 30,000 coverage of expenditure for lower and middle income people. And then now we have ABPMJY, that is Ayushman Bharat scheme, where what we are trying to do, we are trying to cover the bottom 40%. And in that case, you do not have to pay any money, and you will be getting the scheme based on the eligibility criteria. We have a lot of eligibility criteria. So based on that, you will be getting the insurance scheme. So that's how we are trying to simplify it. Obviously, it's not very easy, but yeah, we can do with the help of publicly funded health insurance schemes like Ayushman Bharat. I hope it answers your question. Regarding the second question, so why I have chosen people above 45. Obviously, yes, you are right that it is excluding a lot of people. But the thing is that more or less we are using health insurance, or we need health insurance when we are little bit of in the higher age category. And that was the particular reason. That's why I chose people above 45. And the data which I am taking, that is longitudinal aging study of India, that also covers people above 45. Obviously, we can conduct a study on people who are below 45 also. But yeah, the objective for this study to cater one vulnerable population, and that's why I have selected people above 45 and the data I have chosen. I hope it answers the questions.
Yeah, thank you.
Thank you.
So now, Gautam, you have one question.
Thank you so much for the question. Regarding the choice of that particular variable, right, dependency ratio, I have incorporated that household size in the model, but typically haven't chosen that dependency ratio, right? So thank you for that question. I'll see on that and thank you.
Thank you for your question. I'll start by saying that that's not something that we're looking at. It's just not within the scope of the paper. But it's a very important topic, and there's a lot of health research being done around exactly this concept. And it actually aligns more closely with the broader scheme of the work that we're doing, which is around community health workers. And that has been a very, very effective and very important bridge to sort of connecting people and professional healthcare, if we call it, we don't call it informal. So the mindset of going to seek healthcare and seek professional healthcare, is something that's I think shifting, and it's shifting largely because there's better access, because people are going door to door to inform them, to raise awareness, and to provide support. And I think the other aspect of it ties very closely to the concept around insurance, the concept around health expenditure and government health expenditure, right? Like if we're not investing in our health system, then why will people trust it? So, like I was saying, when we were doing our research, one of the things we found is that at community clinic level, which is at like the very small village level, the sorts of clinics that exist, they're not well funded. They're usually just one room with just one table, no medical instruments, no medical setup. The doctors hardly arrive there because they don't get their wages. There's a lot of different factors that play here. And until we sort of improve our health infrastructure, it's going to be very hard to convince someone. I wouldn't be convinced to go to a community clinic if I was living in that village. And so I don't think it's fair to just put it on a patient mindset, but rather look at it more holistically as a systemic issue that we need to address.
Thank you. Any other question? If there is no other question, maybe we can go to the conclusion of this session. So I would like to thank Sanim for inviting me to chair the session. It's always a pleasure to come here and be part of Sanim annual conference. I would like to thank all the presenters for their hard work and presenting and sharing their findings and methods, which definitely triggered some follow-on discussion today. I would really like to thank Abdullah for his real critical analysis of all the presentations. I think we should take it very positively because he has really, gave lots of effort to look into all the papers and gave some really fruitful, effective feedback. And I think what he tried to convey is that you definitely need to publish the papers. And if you really want to publish the paper, he gave from the reviewer's angle that what you will get from the reviewer. So it's a good time that you take those steps and revise or refine your methods or writing so that you can really publish the paper. I think I really like the comment because I work in the policy arena, so that whatever we do, the research, of course, publication is really important, but in Southeast Asia, the policymakers are so busy, they will not read the 10-page, 15-page research articles. So we have to convey the messages in a way that the policymakers get the message from these publications of what is relevant for them. Of course, you have to prove that your methods are rigorous enough so that that can be translated into policy and action. But I think the policy implications are so important nowadays. So publication is important, of course, as academician, but I think the most important part is the policy influence. I would like to again congratulate all the presenters. I think, and also Sanim, because selecting the papers which mostly focused on non-communicable disease, which is a burning situation now in these areas, which is very expensive. And treating non-communicable disease takes, time. It's not curable. So it takes longer time. The rest of your year, you have to invest at the individual level, at the system level. So that investment is required. So I think this session rightly selected some of the topics that are quite relevant. So I would like to congratulate Sanim for that as well. So I look forward to joining the next year's annual conference with a lot more exciting presentations in the health economics session. And I'm happy that we are prioritizing health economics or healthcare financing, investment in health in different conferences. That's commendable. As I started saying that health economics, healthcare financing, health investment always received less prioritization. But if we really want to develop our nation, if we want we have to invest on human resources, and investing in health is one of the way of investing in human resources, developing human capital and increasing the productivity and increasing the GDP as well. So health and education, these two sectors need lots more prioritization of the government, and this type of sessions definitely can contribute in drawing attention of the policymakers. I hope that there'll be some summary from this session, publicizing the key findings from this session on SANEM website or writing some blogs on the newspaper. We are also very happy to support if needed. So I think that will not, be confined in this room, but this recommendation, all these findings will go beyond this room and draw attention and the wider policy arena. I again want to thank you all for being here and looking forward to join the next annual conference as well, if not before that. Thank you. So we now hand over the certificate. So I request
you go first.
we just start. So Selma, yes, one second. Thank you. Congratulations. Congratulations. So I will now hand over the other presenter, Padam Raj. Yes.
Thank you.
Thank you, Dr. Milin and Asmin, for being with us. We missed to hand over the certificate in person, but I'm sure the SANEM will share those certificates to you soon. So thank you for being with us. Thanks.
Thank you. Thank you, ma'am.
Thank you for having us. Thank you.
Thank you.